So today's topic, identifying and preventing gangrene. Many of you may say that gangrene is not our cup of tea, but unless we identify and we refer, patient will wait till it is very late and amputation is unavoidable. So what's gangrene? It's a condition that occurs when small part of the body tissue organ dies. So you may say that even heart attack is part dying, even stroke is part dying. But gangrene is different. We will see how it is different as we go ahead. Caused by loss of blood supply due to an underlying illness, injury, or infection. Heart attack and stroke are basically stoppage of blood supply due to atherosclerosis. Fingers, toes, and limbs are most often affected. Gangrene can also occur inside the body, damaging organs and rarely muscles. What are the commonest organs being affected? Intestine. Mesenteric artery thrombosis can give intestinal gangrene, part of the intestine gangrene. Obstructed hernia, if delay in surgery, the part of intestine that is obstructed may turn gangrenous. There are different types of gangrene, but all require immediate attention. Basically, dry gangrene and moist gangrene. What are the causes? As I said, stoppage of blood supply, infections, and trauma. Any condition that affects blood flow increases the risk of gangrene, including diabetes. Diabetes is the biggest cause of gangrene, largely because diabetes leads to atherosclerosis and diabetes leads to neuropathy. Atherosclerosis or peripheral arterial disease, which is arteriosclerosis, age-related and smoking-related. Smoking, heavy smokers more likely to have either Raynaud's disease or peripheral arterial disease. Trauma or serious injury. Somebody meets a road traffic accident, has a crush injury on lower limb, that lower limb can get amputated because of gangrene. Obesity, very rarely, obesity may also cause lack of blood supply and gangrene. Raynaud's phenomena. We don't see it much, but it's a condition in which the blood vessels, superficial blood vessels, they become narrowed intermittently, leading to cyanosis and maybe gangrene. Types: dry gangrene is a condition that results when one or more arteries become obstructed. Of course, wet gangrene also is similar, but dry gangrene is different in a way. In this type of gangrene, the tissue slowly dies due to receiving little or no blood supply. But it is not infected. This is dry, no infection, no pus cells. The affected area becomes cold and black, begins to dry out and wither. It actually shrinks and eventually drops off over a period of weeks or months. So I'll give an example. Suppose you tie a very tight tourniquet to your little finger. In some hours, it will give you numbness, tingling. Maybe in few days, if the tourniquet is really tight, stopping the full blood supply, it will become bluish, and then maybe in a few months it will fall off because of gangrene. That is dry gangrene. Look at this. There is no infection, no pus, no discharge. Dry gangrene is most common in patients with advanced blockage of arteries, arteriosclerosis, resulting from diabetes, atherosclerosis, gangrene of bowel due to obstructed hernia, mesenteric artery thrombosis, gangrene of crush injury is always wet gangrene or moist gangrene. Look at this now. The middle toe is gangrenous and other toes also are not looking healthy. It's unhealthy pink. This is the place when we have to start identifying gangrene. Then we have moist or wet gangrene. May occur in the toes, feet or legs. After a crush injury is very common, or a result of some other factor that causes blood flow to the area to suddenly stop. But most likely it is a crush injury. When blood flow stops, bacteria begin to invade the tissue because blood carries lymphocytes and other immune substances that help the tissue fight infection. These bacteria invade and then they multiply very fast without any interference from body's immune system because the blood is not there only, there is no immunity. Almost always involves an infection. Burns or trauma in which a body part is crushed or squeezed can quickly cut off blood supply to the area, killing tissue and raising the odds of infection. There is swelling, there is inflammation, there are blisters. It's called wet because it's forming pus or it is discharging. Infection from wet gangrene can spread around the body, causing sepsis and risk to life. That is why most gangrene, wet gangrene amputation, limb amputation due to injury are done in an effort to salvage life or salvage part of the limb. Like if I have to do today, I have a foot crush, I have to do below knee amputation, I wait too long, I may have to do above knee amputation. Who's more at risk? Any patient who has a risk of blood supply stopping is more at risk for gangrene. Mainly a disease like diabetes, which is poorly controlled. A heavy smoker, 20 cigarettes a day for 30 years. Yes. Or a patient of altered immune system may get Raynaud's. Condition that can affect blood vessels and increase the risk of gangrene, diabetes, uncontrolled diabetes damage nerves as well as blood vessels. Atherosclerosis, because the blood supply gradually stops. Peripheral arterial disease, again because of atherosclerosis. Raynaud's phenomena, we already discussed, where the peripheral arteries are naturally narrow. This occurs because of arterioles, tiny arterioles or capillaries, not because of large vessels. So any further narrowing due to disease can cause cessation of blood supply. Patients with diabetes have an increased risk of developing gangrene. So if I say you divide in two large groups, I would say trauma and diabetes. This is because high blood sugar levels are amenable for bacterial proliferation. The bacteria thrive in hyperglycemia. And because it also causes neuropathy, patients cannot feel when they get hurt. That is why foot care is a very important part of diabetes management. Diabetes also leads to atherosclerosis. Actually, it is a reverse. Hypertriglyceridemia and low HDL are the precursors of diabetes. Then comes pre-diabetes and then comes diabetes. So most patients of diabetes will always have dyslipidemia. And then because blood supply is less, the nerves are getting less supply, less immunity, chances of infection are high. We all know diabetics harbor infections. We'll show you how the feet care is to be done. Then peripheral neuropathy. Patients cannot feel when they get hurt. I recently had a patient who's not a diabetic, not an alcoholic, doesn't take alcohol at all. He had sarcoidosis few years ago, now controlled. He hit his foot somewhere, his little toe got fractured, and he didn't have pain. We got his EMG NCV done, gross axonal degeneration. So, neuropathy patients, just imagine a fracture he does not feel. How will he feel tiny injuries on the sole? Diabetic patients get accidentally injured. Anyway, the skin at the sole is thicker than skin at the palm. So even tiny injuries don't give the perception, but then they are not aware because their nerves are dead. And it is said that when a patient is diagnosed of type 2 diabetes, 20% will already have retinopathy and or neuropathy. Because pain is our savior. Pain is our survival mechanism. It tells us we touch a live flame, our hand pulls back because our nerves tell us. And when in diabetic there are injuries, they don't come to know. We have seen patients where the ulcer on the sole has become so deep, you can see the metacarpals, but patient has not realized only. Look at this. On the left is healthy foot, on the right is ulcer. These are trophic ulcers because of diabetic neuropathy. So patients with diabetes, chronic hyperglycemia, their sugars are always high. And if you think no, that patients control sugar, please wake up. Even in American studies, only 3 to 4% patients give a normal glycemic response across the year. That means all 4 HbA1c below 5.8, 5.7. All fasting PP normal. India you can fathom because people think ki little sweet you have to eat. So the complication of diabetic foot. Diabetics are at a risk of stroke, retinopathy, myocardial infarction, diabetic chronic kidney disease, and diabetic foot, which generally leads to amputation. This is called sensory diabetic neuropathy. If we or patients do not feel a cut or sore on the foot because of neuropathies, then the cut gets worse and they can get major ulcers and may even get gangrene before you realize. Just 1 second, somebody's come here. having a meeting. Put it there. So our nerves handle our muscles. Efferent nerves make muscles do the work that they're supposed to do. If these nerves are not there, then muscles don't work. People are not coordinated while walking, and that also causes minor trauma to the limbs or the feet. This causes the foot not to align properly, too much pressure. So, pressure ulcers occur. Up to 10% patients with diabetes will develop foot ulcers. 10% is a large number. Foot ulcers occur because of nerve damage and peripheral vascular disease. Look at this. This patient has not realized, and these are pressure ulcers because of incoordinated walk. Look at this. These are callosities because of incoordinated walk and neuropathy. This patient gradually will start getting ulcers without realizing. Peripheral vasculitis, so diabetic foot has three components. One is neuropathy, one is peripheral vascular disease, third is infection. Without good blood flow, it takes longer for an ulcer to heal. Poor blood flow in arms and legs is called peripheral vascular disease because arteries of the periphery, heart is in the center, kidneys are in the center. Then if there's an infection, it doesn't heal because of neuropathy as well as arterial disease. Look at this. This is the progression of a diabetic foot. First is diabetic foot. You can see a little abnormality here, but there is no open ulcer. Then you have a superficial ulcer, deep ulcer, abscess or osteitis. You can see the metacarpal there. Then forefront gangrene has occurred. The ulcer has become so big and this entire foot has become gangrenous. And we have to identify our job grade 1, grade 0 to grade 2. Grade 3 abscess osteitis, very, very difficult to treat. See, this is how we teach patients. Everybody has a dressing table in the house. So we tell the patient to put the foot there and look at the sole for any ulceration. See this, the patient can check weekly. They can check whether there are ulcers or not there. Please train patients to teach them. And when they come to the clinic, make them remove the socks and examine like this. We have to examine in between toes. Then what do we do? First is when you suspect gangrene, refer immediately. Need not have a diabetic foot surgeon. A general surgeon would be good enough. Immediate intervention, because my job right now is to salvage the tissue. My aim is to avoid amputation. Even a little toe, avoid amputation. Prevent progression to irreversible damage, infection, or gangrene. Early recognition, prompt treatment of whatever has caused it, infection control if there is infection, and blood flow restoration. All these decisions the surgeon can take. If the gangrene has occurred over a very short period of time, they may do angiography, find an occlusion, and maybe do a balloon angioplasty or put in a stent. What are the early clinical actions we should do? Recognize the early warning signs as I showed you the picture. Pain, numbness, discoloration. Discoloration is a red alert. Blue, black or green, whichever. Any swelling, any foul smelling discharge, especially in a diabetic, you have to immediately think of possible gangrene. Learn to feel peripheral pulses, dorsalis pedis, posterior tibial. And if you cannot feel them, immediate referral in a smoker or uncontrolled diabetes. Socks are a problem in missing out because we make patients to take off shoes outside, but socks are always there. Carry out physical examination, pulsations, blood test, infection marker, CBC, CRP, procalcitonin if you suspect sepsis, and creatinine because infection and sepsis, first it causes is acute kidney failure. And imaging, Doppler, CT, MRI. So it's best to keep talking to a surgeon and then take a call. Antibiotics, oral antibiotics generally are not sufficient. You have to give intravenous antibiotic. If you can give good, otherwise admit the patient. The specific antibiotic may be adjusted once the causative organism is identified from tissue or fluid culture. Just a minute, maybe somebody's come. I'm sorry today. Who's that? Pardon? I need, no, I don't need. I'm giving more. Sorry. Even before you do culture of the pus or discharge, you should start a broad spectrum antibiotic intravenously. Improving blood flow. Whatever you can do to improve the blood flow, you have to start doing. You can give blood thinners, you can give aspirin, you may start heparin, you give statins and some vasodilators may be required. Because blood is required, it gives oxygen, it gives immunity to fight infections. Minimally invasive options like angioplasty or stents may be done if they find a blockage which is treatable. If it's a peripheral arterial disease due to smoking or Raynaud's, then all these things may not work. And wound care. You have to learn proper debridement because here you need to keep removing dead tissue and salvage the tissue. Proper wound management, daily debridement, cleaning with sterile solutions, and specialized antimicrobial ointments to make an attempt to heal it, avoid amputation. Lifestyle management. Quit smoking. Control diabetes. Stop sweets. Control blood pressure. And start walking if they can because that improves the blood circulation. Tissue, understand one thing, if tissue is damaged by gangrene, whatever you do, you will not be able to save it. So prevention is the only cure everywhere, but more so here. Hyperbaric oxygen may be considered, but the research does not say it is very effective, and availability also is limited. How do you monitor the patient? Early surgical consultation, and you treat with guidance of the surgeon. Amputation is reserved only for non-salvageable tissue. Otherwise, debridement only is a must. Regular monitoring of patients at risk diabetes. If, my dear friends, you are treating diabetes, the monthly, 2 monthly or quarterly visit, you have to examine feet. Patient education, early signs, check your soles regularly in the dressing table mirror is a must. People have to learn. A diabetic can never wear shoes without socks because you don't know what is inside. They have to wear socks. And nowadays, there are special diabetic socks which don't have seams. But I'm not saying you spend that kind of money. But a diabetic has to wear socks if they are wearing shoes. Thank you. Dr. Chaya, preventive measures are this only: foot care, control of diabetes, quitting smoking, and if there is peripheral arterial disease, to keep treating regularly. Now, peripheral arterial disease and diabetes are lifelong ailments. So, my job is to prevent. I have to check. I am a diabetic. I check my feet regularly. So, all I'm saying is these are something which we cannot avoid once it occurs. Best is not to let it occur. Thank you very much, friends, for your nice comments. Next week, I will not be available. I am taking a lecture in Pune. So I'll be on my way back. We'll meet you week after next. Thank you.